right.
Are you doing this? Are we on?
Yep, we're on.
Testing.
Oh, it's already on.
Oh, God,
it's
that's
been
so
recording for
exciting.
about 5 minutes.
Okay.
Oh yeah, I'm editing it. So.
Oh,
Yeah.
please. Oh, that's always a nice thing to have available.
Oh yeah. So I'm gonna make everyone look really good and airbrushed and everything.
God, honestly. Wow.
Okay, all right, everyone. Thank you for coming to SWOC. We're going to get started today. Well, actually, before we get started, let's go over a couple things. Next month, we're going to have SWOC here. We're going to have a physical therapist who specializes in continence issues. We frequently don't do continence with our certification, but a lot of people requested it when we sent out the Survey Monkey. A lot of people want to hear about it. And she's going to be focusing on curative continence. As nurses, we normally only deal with patients who are never going to become continent again, and we're just doing containment. But this is going to be working with patients who can be fixed, who can become continent again, and all those options. So this way you can add that to your tool belt, and even if you're not continent certified, you'll at least know about it, and as a nurse you can make some recommendations and education to the patients. So. And then November and December we don't have SWOC, and November is when UW does their wound update conference, and we want to encourage people to go there. And then in January we'll start back up again. And the good news, and it doesn't really apply to those of us here, but starting in January we are going to start having SWOC meetings in South King County too. So we'll record the meetings here. And then the next week we'll have a meeting down south, so all the southern South King County nurses can meet and start networking and socializing. So, so there you go. Any questions? Yeah.
Yeah, because I never go to South when they are so I imagine they never come here because of
That's
the
right.
traffic.
They really want to be involved, but they can't. So.
Are you looking like at Highline and Valley?
We've reserved a room at one of the Providence buildings in Tukwila.
Oh.
And we'll see. I mean, we don't have to hold it there. So if somebody finds a place they want to have it at, that's more convenient for everybody. Hey, we'll do that. Mm-hmm. Yeah. Okay. So tonight, our Laurie here is going to talk to us about what is reimbursement for Medicare and all that. We all need a lot of help, and so thank you. We really need this.
Thanks so much, Deborah. It's really nice to be here. I am Laurie.lordhambrecht. Actually, for many of you who know me, I came into out of bedside care into industry, and the same year I got married, and everyone knew me as Laurie Lord. So I added the Hambrecht far later on because I figured if I went out in industry and was Laurie Hambrecht after I've been Laurie Lord forever, nobody would know who the heck I was. So I've added them all. So that's why I have such a long name. I've done many things in my career, as many people in this room can attest. I've worked probably with everyone here. Yes, I think that's correct. And I've done a lot of different things. And my most recent employment is with CCS Medical, and we are a multi-diverse DME company, national DME company, and I am the VP of the wound care division and create programs and education for payers, and we'll get into that a little bit later, but it's very, very important to understand how to access benefits for the patients, and I have learned so much in the last 3 years that I'm excited to be here and to impart some of this information that I've learned with you. And I have a lot of tools available, so we're going to go through. I have packets, and I've provided you the presentation. So because there's CEUs that you will be receiving, we have objectives. And the first objective is you'll be able to list 2 distinct documents that make up the Medicare Surgical LCD. And I'm going to get into acronym description, so just hold on there. And then the next would be describe the 2 parameters explained in the Medicare Surgical Dressing LCD associated policy article that qualifies a wound for eligibility. Now, that's a big piece. Just because somebody has a wound, it doesn't mean that that wound qualifies for the Medicare benefit for their surgical dressings. And then the third is list the 2 advanced wound care absorptive dressing categories that are determined to be medically necessary for a daily change frequency under the Medicare LCD for eligible beneficiaries. So there are a lot of words in that last objective, but there are a lot of things that have to be met as far as criteria. And it seems like I see a lot of full thickness wounds with heavy drainage where the providers aren't necessarily sure of the frequency and not necessarily sure of what actually is covered and what is not. So we're going to review that. Next. So I just want to take this moment to let everyone know what's in your packet. If you open your packet, on the right side is all the Medicare information, and on the left side is the clinical information, and we have to marry those two to make this make sense. Okay, so when I started working for CCS Medical, I had worked alongside many DME companies, but I'd never worked for a DME company. And let me tell you, it was a rude awakening. I would say to my vendors, my vendor experts, you just handle that, because I'm busy over here with, case managing, running clinics, doing all the plan of care issues. And so when it came to the dressing supply, I knew that there was a lot I didn't know about it. So I would enlist the experts with the DME companies to assist me. Well, then all of a sudden now I have to create programs and go out and be that expert. So I had to learn more about Medicare than I knew, because I knew just kind of skin the top of Medicare. So what I did is I researched. I wanted to know, what exactly is this thing we call Medicare, and where is it in this government entity? So actually this slide, it lists for you all of the different divisions under the Department of Health and Human Services, of which, if you remember, if you've been around as long as I have, HCFA, the Healthcare Finance Administration, used to be the old acronym to describe CMS, and they changed to Center for Medicare and Medicaid Services, I want to say 15 years ago, or certainly over the last 10 to 15 years. So the division is the same, it's just the terminology has changed. So now CMS, and they don't have two Center for Medicare and Medicaid, they just have one M. CMMS. So, but all of these other divisions are under the U.S. Department of Health and Human Services, and that was helpful to me to understand where Medicare sort of originates. The next slide then, Jen. And I wanted to have factoids, because let me tell you, this is sort of, I live my life in analogies, because I've had to train patients. We do a lot of training, as you know, and I like to take very complex information and make it understandable. And in order to do that, I have to understand it. So I wanted to put some factoids about Medicare that actually I did not know. The insurance, what actually is Medicare? When did it originate? And Medicare's been around since 1965, and it was President Johnson who was in office when Medicare actually was developed. The program currently contracts with between 30 to 50 different private insurance companies that administer the program. So when you talk about a Medicare Administrator, or the acronym for that is MAC, Medicare Administrating Contractor, or the MAC, people say, who's your MAC? It's different for what benefit you're looking at. A Part A Medicare benefit is administered from different entities than the Part B DME. I'm in the DME world, so we actually have 4 Medicare administrators around the nation. Well, I'm sorry, we have 4 regions and 2 MACs. They do 2 regions each. And I have a slide in here for you, actually in your packet, and it's a colored slide, and I'm very visual and I love different colors. So when you see we are on the West Coast, we are in region D as in dog. Region A is up in the Northeast. B is in the Midwest, C is in the Southeast, and D over here on the West Coast. Our MAC on the West Coast for Part B, durable medical equipment, is Noridian. So you will hear Noridian's name a lot associated with Medicare claims, adjudication, and audits, et cetera. And that's because they are the DME MAC for Part B claims in Region D. Another thing about I wanted to know how's Medicare funded. Well, several taxes. It's the payroll tax, premiums and surtaxes from beneficiaries, and a general fund. Medicare provides health insurance for Americans aged, now of course there has to be qualifying criteria. So 65 and older who have worked and paid into the system through the tax, the payroll tax, but also, as we see in our practice, it provides insurance to younger people with certain disabilities. So, and those are determined by a Social Security Administration, as well as people with end-stage renal disease and those with ALS. So there are criteria by which younger people under 65 can qualify for Medicare. You have to apply, be evaluated, accepted, so you have to qualify for it. Oh, we'll go to the next slide.
Those are only the two chronic diseases, ALS and end-stage renal?
End-stage renal and, well, you to get automatic benefits, you can qualify and Medicare will evaluate for a disability, but those are automatic.
Okay.
Yeah. So I was very interested by this slide, and what this slide does is show what I have learned over the last 3 years, which I knew not a lot about, and that is where the Medicare dollars are going. And you really, when you have benefits, these eligible beneficiaries have the right to the benefit. The thing about it is traditional Medicare programs are really going away and they're being replaced by Medicare Advantage plans. When you hear that word Medicare Advantage plan, people think traditional Medicare. It is not the same thing. Okay, so if you see over here, the box in 2007, the Advantage plans were in the red box. So traditional was 70% and Advantage plans were 18%. And then the third color is the Part D pharmacy plan. So if you take it from 2007 and go out 10 years, you can see now that from 18% to 30% are Medicare Advantage plans. So there's been a huge shift. And that's very, very important because there are so many different plans that default to Medicare guidelines. Well, we follow Medicare guidelines. Medicare Advantage plans, of course, as you know, traditional Medicare does not provide dental. They don't provide vision. So they're incentivized, the beneficiaries are incentivized to join the Advantage plans. And that it changes because they go out now, the risk. It's all about following the reimbursement, the risk, the monies that come from Medicare to the plans. You follow the risk. And traditionally, for those of you in home health in the room, Medicare home health meant it was the monies were going directly to the home health agency, and a DME company that is shipping dressings would not be able to be engaged. But now, with Medicare, the onset of Medicare Advantage plans, the contracts are with the plan and the home health agency, so thus a company like CCS Medical can supply the dressings. So it's really kind of changing the horizon of how we look at providing services, accessing benefits, et cetera. So I thought that was a really interesting visual. Is this something that you're seeing a lot in your, I'm not sure because, but home health. Yeah, right. Well, you know, the good news is now you have my card. I'm your benefit access specialist. Okay, exactly. I mean, this is exactly what the information, for me, it was like, boy, I better stay up at night learning this because it was in a completely new avenue for me. We'll go to the next slide. So I really, for me to understand and go out and train people, I had to understand what kind of money we're talking about that's passing through hands here. 2017, we're usually about 2 to 3 years behind in the data just because they amass so much data. But so in 2017, Medicare accounted for $7.2 billion. They are the largest insurer in the nation. and that's out of the federal budget. And you can see there all the other things like federal defense, Social Security. Medicare's 15% of that entire budget. That's a lot of money. And so Medicare wants to make sure that they are overseeing the expenditure wisely. And that's where the Medicare is becoming more, they're refining their audit processes. They now have what's called a TPE, which is a target, probe, and educate, which is sort of like the old, when they would audit you or you would be under survey. They have changed the process now, and you get a couple of times to be re-educated, and they arbitrarily pull claims, and if you don't show improvement, you could lose your Medicare license. So they're not messing around. And that, the thing is, fraudulent Medicare billing is epidemic. And so, they have to refine their processes to ensure that all the bills that are coming in are not false bills, they're clean claims, and that they are responsible for paying for those supplies that are part of the benefit. So when you get into, now there are a lot of criteria that have to be provided in the event that Medicare pulls a claim and says, well, we'd like to review the claim for the order from the clinic visit, let's just say hypothetically, that was conducted November 18th, 2018. So they reserve the right to do that. So what happens is there is data, and I'm going to go into this, there is an enormous amount of data that Medicare requires to have available to review upon their audit. And there was a lot of pushback. I joined CCS Medical in May of 2017, and I had heard a lot, at that point, a lot of pushback from the marketplace and the industry and providers just sort of coming into this sort of new arena, that the documentation was onerous, it was laborious, it was just too much. And so to that end, the 4 medical directors of the different MACs, the Medicare administrators, have written a letter. This is the Noridian MAC letter, and there is a corresponding letter for the other CMG administrators for the other MAC that explains to providers and healthcare industry participants why this data is so important. So it's really, Medicare understands that they have a lot of data, but they feel it's necessary to validate the $7.2 billion that they're spending on DME. So this letter actually was dated October of 2018, and again, I got here in May of 17. So they actually responded. They were responding after just about a year of, or a year or two of all of this industry feedback, negative feedback, like why is all this documentation required? So you have that here. So when you're talking about dressing supplies, how many of you have not heard the acronym LCD when you're talking about, okay, LCD, okay. So it's actually, CMS has guidelines for everything, and I'm going to be speaking just dressings, but they have guidelines, and they say for a Medicare beneficiary who has applied for Medicare, been accepted into the program, they have a right to benefits, of which one of those is called a surgical dressing benefit. Now, why they called it surgical, it's a little misleading, but I digress. So a surgical dressing benefit. And they have to have guidelines, but they have guidelines for everything. They have guidelines for prosthetics. They have guidelines for pharmaceuticals. They have guidelines for all different types of things. But the guidelines themselves are called local LCD or local contract determination. So it's a local interpretation, local coverage, I'm sure, determination. So basically what it's saying is, these are the guidelines that have been developed by the medical directors and, other medical industry participants at large, and we have come together with best practices, and that's what these documents are. The LCD, there are 2 components to the surgical dressing LCD, and you can look this up on the CMS website, and I will give you a link in a moment. But I think it's really important for you to understand there are 2 pieces to the surgical dressing LCD. One of them is the LCD itself, which gets into the dressings and medical necessity and what documentation is required. And this is the L33831, which is your first packet that you have in there. Behind that is the associated policy article. And this document gets into more of the specific nuances of the guideline, like what units are billable in measure, if it's an amorphous gel, what kind of, what is, I'm trying to think, what is not considered a covered item? You're going to get that kind of information out of the associated policy article, but they both work in tandem together to define the benefit and whether a beneficiary is eligible. So you have these now. They're also electronically available on the CMS website, which it took me about 3 months to find where they are, but they are definitely in there, so I thought I would provide those to you, because these are the rules of the road. Anything that you question, and like I said, my analogy is I used to push IV heparin for a living. I need to know why I'm doing things. I just got very used to that in the ICU. I would question, why are we developing the plan like this? And I've taken that throughout my entire practice. So I want to know the whys. When people come back to me and say, oh, this claim is denied, essentially that's saying to me, somebody who has a wound, who is in need of a dressing, their insurance company is saying, no, we're not going to cover that. Why? And this is the descriptor, these two, and I'm going to get into these because that is really what the definition is. Next, let's see, coverage. Okay, so obviously you need to know the coverage indicators. You need to know, is a patient eligible for Medicare? I mean, that's important to know. If you're not Medicare eligible, you obviously can't access benefits. The benefits, now this is one where we're all around the room going to say, well, what does that mean? Reasonable and necessary and medically indicated. Medicare has come together and made clinical decisions about what is reasonable and necessary for frequency changes, for instance. What is reasonable and necessary for like a calcium alginate on what kind of a wound? How do you qualify a wound? It's all in here. And that they meet all the other Medicare statutory requirements, which are voluminous, like attestations, signatures. You can't take stamps for dates, things like that. Next. So, 2 distinct parts to the Medicare surgical LCD, and we're going to go over each of them briefly, but why they are different. Okay, so the LCD is the first one, and it is advanced wound care products and standard documentation requirements. Let's go to the next slide. Next slide. So this is where you would get your www.cms.gov if you wanted to access these documents. It describes Medicare coverage criteria for specific types of care, describes Medicare coverage for several product categories, and we're going to get into that. And this document, the L33831, contains medical necessity requirements, which is very, very important, and documentation requirements. Next. And these are the documentation data points that are required to submit a clean claim. You have to have a prescription, you have to have orders. And the thing that's really interesting is that the orders have to match the clinical documentation. So just to write out something on a prescription pad and send it in, that is not going to be a valid prescription. Medical record information, now this wraps around to everything that we've been talking about. It's very, very important that what has been ordered aligns with the clinical documentation. And oftentimes they don't, and that is not considered a clean claim.
Is this to prevent fraud?
Absolutely, yeah. And again, the $7.2 billion that Medicare is spending in 2017, and I'm sure it's exceeded that over the last 2 years, they want to make sure that their expenditures are prudent, that they're clinically necessary and medically indicated. And they define what that is. If you participate in the Medicare and Medicaid program, you are agreeing to abide by the policy and the laws that have been assigned to that program. And if you don't do that, as it turns up, if you go back and there's a target, probe, and educate, and 40 claims are pulled in 2018 for a particular either provider or third-party DME company, and those aren't aligned, it's a red flag. Because basically, that's a fraudulent bill that went out, and they paid it. And they're saying, oh, wait a minute, things weren't in alignment. First of all, what they're going to do is they're going to target. And it seems like DME, as far as dressings now, have been a target over the last 2 years. Before that, it was pharmacy. I mean, Medicare kind of goes through its waves of focus. So, but not only do they target and pull and continue to pull, and then you're expected as an entity, as a DME, for example, to improve on the documentation and a clean claim percentage, or you're running the risk of losing your license. And you have to pay the money back that they paid you at the end of fiscal year 2018. So it's a hefty problem. So all the things that would be required would be obviously physician's record, hospital record, nursing home record, home health records, community-based records. They can say, we need all of these to review. You have to have correct coding on your claim, and you have to show proof of delivery. And that means that we, as a durable medical equipment company, need to contact directly the recipient, who would be the beneficiary, and say, this is this company, we are sending out these dressings. Are you in agreement with that? So there's no auto approvals. You have to actually, and it's getting more difficult, especially with the elderly. Not always do they have phones. Do they know how to use phones? Some are on flip phones. Some you can't text. So a lot of times it is the adult child or the guardian that we have to make sure that we know, so that people can, but we cannot ship without having that approval. Next. So then you're getting to the policy article, which is really, they work together, but this one is very important. And when I started with this company, I'm not sure that this standard was really understood universally. I can certainly say that it wasn't by me, and I worked in wound care half of my professional career. So, you can't be experts in everything. So this is something that's a real important issue with the Medicare surgical dressing benefit. There's two separate criteria in the policy article. One is necessity for and determining a qualifying wound. Just because a person has a wound and they're a Medicare beneficiary does not mean that that wound qualifies for the dressing benefit. And the second is the requirements necessary for any product to be classified as a surgical dressing. Not all dressings are qualified as surgical dressings under the benefit. Okay. Surgical dressing. So you would ask, well, what in the world? How do you qualify a wound? Dressings are covered when a qualifying wound is present. A qualifying wound is defined as either of the following: a wound caused by or treated by a surgical procedure. Any surgical procedure, right? Or how many of your wounds you're seeing now are the direct result of a surgical procedure? But think about it. If they're venous, probably not originally. If they're arterial, probably not originally. If they're abscess, probably not originally. You have to think. That's why etiology is very important. Because if you haven't had a cholecystectomy and a surgical incision that's dehisced, you have a spontaneously developing wound. That wound is at risk of qualifying if there hasn't been a debridement or some sort of surgical addressing to remove the non-viable tissue. Very, very important piece. Now, the problem with this is a lot of the electronic medical records are not updated to capture if it's a debridement that was done 6 months ago on that left lateral malleolar wound. That qualifies it. So it's 6 months later, that wound is still open. We're trying different plans of care. There might be a peripheral vascular component. But if it's been debrided, now who wants to sit there and go through 6 months worth of EMR records? So our platform is Brightree. I don't really know what other DME companies use, but we are actively pursuing upgrades in our system, so things like that will be right there when you open up the record, so you know the last date of debridement. So it could expedite processing of things, because we have to find that out, because again, we are all sort of prudent caretakers of the $7.2 billion of the Medicare expenditure for these dressings. And if a wound isn't qualified, it doesn't qualify for the dressing. Hi, come on in. Hi. So a wound that requires debridement, and those are going to be all of your wounds. Now, one would say, well, we're going to get into partial and full thickness. Do you really debride a partial thickness wound? Well, you need to document that you at least are removing non-viable tissue, because Medicare wants to make sure that that wound is in the most optimized healing environment. And if you have non-viable tissue in a wound, that flies in the face of that goal. That's the rationale here. And let me tell you, I've talked to many Medicare surveying nurse or overseas clinical coordinating nurse, and that's the rationale. And it makes sense, does it not? I mean, it does. They're not saying that you have to only have sharp debridement. They are not saying that. The surgical procedure debridement, it must be performed by an adequately licensed personnel. It can't be done by people who aren't licensed to conduct that kind of a procedure. Okay, Deb, next. Wound debridement. How often do I either get on the phone, involved in a TPE, talk to vendors, talk to providers, talk to clinical colleagues, and they say, well, they didn't get it sharply debrided. I mean, we aren't a wound clinic, or we don't have, our doctors don't have scalpels. There's more than one way to debride a wound. It has to be in the documentation. It has to be in the documentation. Now, you notice that biologic isn't on here because it's not in the LCD. Biologic, which is the maggot therapy, it's not that common, and it's not in the language. It doesn't mean it's not a viable debridement method, but it's not in the LCD, so I didn't include it. But surgical, of course, is one, and that's the one that the industry really sort of thinks it defaults to for debridement. But there's also mechanical. Like I said, if you have a stage 2 pressure ulcer, you want to get a dressing for someone, for a Medicare beneficiary, taking solvent on a piece of gauze and aggressively rubbing out the non-viable tissue, it has to be documented. That's debridement.
So Laurie, you think that if you don't use the word debridement in the charting, if you're using like moist wound healing, which is autolytic debridement, if you don't use the word debridement as part of your documentation, you haven't done it?
No, it has to be documented, and in the event that there's a denial, basically what we have to do is have the argument. I've been on many ALJ hearings, and we have been able to defend our stance. So, yes, and you'll see in here with hydrocolloids, that's part of the hydrocolloid indicator, is for autolytic debridement to provide a moist environment. So we have to be able to defend it.
Okay.
Yeah, you have to be able to defend it. Enzymatic, the only enzymatic agent that is currently on the market that I'm aware of, I learn from my colleagues all the time, is Santal, Collagenase. If there's something else, please let me know about it. But for right now, that's the only, it is not covered by the surgical dressing benefit, however, it's a pharmaceutical. And autolytic, there you go. There's your moist healing, your moist environment for wound healing. That is liquefying the non-viable tissue, and you do that many different ways, right? With different dressings, etc. But remember, it's got to be documented, but we are missing out on a lot of benefits for these beneficiaries because maybe they didn't get a curette debridement. Well, it doesn't mean that the wound wasn't debrided. Okay, next. Now, this is overwhelming, but I just want you to see what the checklist looks like to submit a clean claim. So if a claim is pulled, we have to have all of this documentation in order for Medicare to review it, consider it a clean claim, and say, oh, great, you did everything, and the money that we spent on that claim is viable, and that's great, and that beneficiary got what he needed. So, but look at this. Patient's medical condition. Obviously, H&Ps are important. We have to know. You can't just have, how many of you have called you, Joyce, and said, I have this wound, what should I put on it? Hello, yeah, I get that from reps all over because I am the clinical expert for wound care in my company for the dressing side of the business. And I've, gotten used to me now. Back up. Okay, I need to know a lot more than that to give you any recommendations or any feedback. So, patient's medical condition, plan of care. Plan of care is so important. Is that, I don't know. Plan of care for me, of course, every everybody works in different arenas. So, but plan of care, it's, week to week, the first 4 weeks, and then you can age out your frequency if you're on a trajectory of healing. Plan of care is so important. If I were a Medicare reviewer, how would I know if a wound is stalled or not if I don't have a plan of care to benchmark against? It's very important. Why are you doing what you're doing? The plan of care. What are the expected outcomes? Frequency and use and quantity. That's very, very important. Frequency, let me just say, and I'll go on record saying this, Medicare has its standards. What they consider medically necessary in a BID and a TID in the post-acute community is not considered medically necessary. If they actually need that, they may need a higher level of care. So Medicare is going to pay for dailies. Anything beyond that that's ordered is an automatic first level denial, and the documentation has to support the plan of care. And we actually have been relatively successful in proving to Medicare in certain instances, but not all the time. BIDs I was shocked at the amount of BIDs that I was seeing out of clinics around the nation, because when in my historical experience, we would try to get wear time out of the clinics. So BIDs to me was, again, it's really interesting how different parts of the country practice.
They're doing what you try.
Right. Yeah, well, we'll just let our mind wander, right? Okay. So, duration of supplies needed. You need to, is this a 30-day request? Is this a 60-day request? And if it's a 90-day request, you better have a new plan of care. It's a palliative situation. I'm out of the hospital. I'm out of the hospital and the clinic. So for me to understand what's going, what the expectation is for the next 2 weeks was of paramount importance. So when I would get out here and see these 90-day CMNs, I was thinking, wait a minute. Medicare's going to pay for 90-day CMN. Wounds are supposed to, and then it became very evident to me that not all wounds are aggressive healing expectation. There are palliative wounds that, yes, Medicare will pay for. But it's really important that you put down the duration of supplies needed. Usually they're 30-day, the CMNs. Eugenia?
Oh, quick question. If the plan of care indicates like it should be a 90-day treatment, and Medicare approved, but treatment plan has been changed, would it be possible to send it back for reimbursement, like a wound supply?
So it's called a certificate of medical necessity that can be on the chart for 90 days. However, an assessment has to be submitted every 30 days. And that's where you reserve the right to really reevaluate where your plan is going. And if the evaluation supports the continued CMN for 90 days, then you would send out an additional 30. But yes, you reserve the right. Now, Medicare is going to not look favorably at every 7 day, a new order coming in. And, because there's that ship time. And you're looking at 3 to 4 days of ship to process and ship time. So these people are getting this arsenal of dressings. So that we have to look at that for sure.
So would it be possible to send, like we use the 60 days, we decided to send back 30 days and requested different dressings?
Oh yeah, you can work with your DME company. They can send call tags, and yeah, absolutely.
And it will be like another process to submit request for another.
That's correct. Every 30 days, yeah. Work with your benefit access specialists.
Oh, we will.
Yeah. Okay. So other therapeutic interventions, are they on HBO? Are they on compression therapy, et cetera? That should be actually it should be, some of these EMRs have a collaborative, the sort of chronological, ongoing description of the wound sizes anyway, and the plan of care, which is really nice. You get a lot of notes, but at least there is no question. The wound assessment, there is just no substitution. They're very, very hard and fast on this. Size of each wound, that is 3 measurements. Length, width, and depth. 0 in depth is not a size that's acceptable. Then, of course, Joyce is going to ask me, well, what about the unstageable? What about the non-classifiable? Well, as I learned when I was working in the clinic, we need to go back and reclassify or restage after at least 30 days when the next QA comes up, because it doesn't stay unstageable for the duration of the wound, right? So at least if there is eschar, you have had full thickness damage, you have at least a 0.1 depth. Because you know that's got to come out. So to Medicare, 0.0 indicates intact epithelium. Okay?
You just guess the 0.
I think a 0.1, you know, is at least a physiologically reasonable response to that, and then to be continued as the next assessment comes up. The location, obvious, the assessment date. These are all benchmarks. Date everything. It has to be dated. Classification. Now we're going to get into this. This is a very confusing area. Classification of wounds. I'm not going to belabor that because I'm going to get it. It's like stage, grade, degree, partial versus full, etc. The wound type. What's the etiology? If you know it, it should be you have an ICD-10 that's going to associate, but some of them are more global than others. Debridement, yes or no? Now we've explained why that's important. It has to be somewhere in the chart. Here, my dear. Poor thing sitting back there with you don't have any tools in your arsenal. The level of drainage, remember, classification and drainage, that is going to drive reimbursement and with Medicare. Okay? And primary or secondary dressing, really the surgical dressing benefit is only paying for primary and secondary. They're not paying for all these different sandwiching, layering. That is not the intent. Signed doctor or doctor written order or PWO, physician written order. It has to include the patient name, please, legibly, the date of birth, the 2 identifiers, minimally, start date of the order. Okay, so usually that's a clinic date. When I get an order in, that's a different date when it starts processing from when the clinic visit happened. So don't you worry about that, let us worry about that, but the date the patient was seen is the start date of the order for intensities of you putting in the order, right? And on the form, you'll see that there are different places for different dates. HCPCS code. Now, there was a time when narrative would suffice for everything, and that time is really going away. It's very scientific now because there are different ICD-10s that identify different anatomical locations, or, well, actually the same anatomical location, but different parts of that, like a tendon abscess versus, gluteum is kind of hard to find, if you notice, on ICD-10s. So ICD-10s, that, and the thing about that is it has to correspond with the dictated note. You can't have an ICD-10 on an order that's different than the ICD-10 in the clinical note, because then that is not a valid claim, and thus, if you are submitting for reimbursement, it could be considered a fraudulent claim. The ICD-10 has to be the same in the physician order as it is in the corresponding clinical notes. Everything's got to match. They don't always, but it's very, very important they do. And Medicare is finding out that they don't always, and Medicare is holding our industry to task for that, as far as the surgical dressing benefit.
Up at the top, there's a line in bold there about heavy exudate or infected. The patient has to be seen by their.
Sorry, I missed that. Well, in the outpatient clinical setting, that the expectation would be the patient comes into the clinic or a home health agency is dispatched. If they cannot meet that requirement, there has to be a descriptor in the notes, in the clinical notes, that states that due to these extenuating circumstances, that patient cannot get into clinic or get to a provider for evaluation, but every 30 days. And they accept that.
Oh, okay.
Yeah.
Because a lot of clinics can't see the patient once a week.
They're getting a lot more vigilant on the Q7-day evaluation for infected wounds, because they're, and I've personally seen a lot of claims where copious drainage goes on for absolute months at a time, which if you have a fistula into your lymphatic system can happen, but really usually copious drainage for the most part is associated with a bioburden or some sort of a local infection or maybe a regional infection of some sort. So that's kind of where they're going. But if you can document, and I've seen it very successfully documented, I'm sorry I missed that, that the patient, for whatever extenuating circumstance, cannot get into the clinic or into a provider, then it has to be at least every 30 days. Yeah. Okay, so the signed DWO, the wound size, the drainage, everything we've just talked about, stage or thickness, which is the classification. Has the wound been debrided? You're seeing that coming up. Duration of need, not to exceed, you're not going to get anything beyond 90 days. Quantity of dressings to be dispensed. So if you want a daily dressing for 30 days, then that would be 30 of your calcium alginate that you're requesting for a particular wound. And then the frequency of use is very important. Again, we've talked about the BID. That's sort of going by the wayside. You can get that in a skilled nursing setting. You can get that in an LTAC. You can get that in acute care. But actually for community-based independent care, BIDs are not considered by Medicare, as I can see, and that this is the information that we've received. They are not considered the medical standard, a standard of care. The doctor information. Okay, so the doctor, this is important. The doctor has to sign. There are no date stamps that are allowed for date. It has to be written in. And the NPI number. Okay, next. Oh, and then the consent. And we talked about the consent. We have to say, hello, this is CCS Medical. We are shipping this out. We have to talk to either the patient or a guardian or somebody who has been delegated to speak for the patient.
How do the hospital patients in the acute care setting get reimbursed? Is it like this?
Pawash, I'm so glad that you bring that up. This is for post-acute.
Okay.
Medicare Part A is a different bucket. They have different MACs or Medicare administrators. They have more Medicare administrators.
Okay,
That's a completely different bucket.
okay.
Yep.
So for nursing homes, the same? It will be just
Nursing homes, not under Part A benefit, but under Part B benefit, yes.
yeah, but it will be the same as
Right, for Part A benefit, that's a completely different jurisdiction. That is a different bucket of money. I'm just talking about the Part B, post-acute. No, that's okay, because that's, how people say Medicare. Boom. That's just the beginning of the discussion in my world. Did somebody else have questions? No? Okay, next. Oh, and the consent, yes, of course. Non-coverage issues. Ooh, I'm surprised the people haven't knocked my socks off about this before now, but this is very revealing. This is right out of the LCD. Examples: drainage from a cutaneous fistula which has not been caused or treated by a surgical procedure. Spontaneous fistulas, they are not considered chronic wounds. And there have been many clinic-based patients that was brought to light on since I've been here. Because I've asked the question, wait a minute, why are we sending out 3 loaves of gauze every 30 days? I mean, so when you ask, why are we doing this? Fistulas are not considered a chronic wound under the dressing benefit. A stage 1 pressure ulcer, by definition, epidermis is intact. Medicare is just, wounds caused by trauma. Now this one is really going to be interesting because it was very, I really question it, because you can see some level 3 and 4 skin tears, right? But then that's a full thickness injury. You wouldn't call that a skin tear. Your nomenclature is very important, because if you call things like skin tears or abrasions, you're eliminating the possibility of really describing that effectively to the point where Medicare will consider it a viable wound to be covered. Now, skin tears, again, I've seen some pretty nasty skin tears, but I would just venture to say that language is not something that, they would zoom in on that.
What if you start getting into the weeds of type 1 skin tear?
That's not...
You have the definition of what type 1 is, type 2 and type 3.
Yeah, Medicare actually doesn't use skin tear classification as one of their descriptors. So we'd call it a partial or full thickness injury with what kind of drainage. I'm just saying that skin tears gives the wrong impression of some wounds that can be very, very, and abrasion as well. If you're into the dermal tissue, that's a partial thickness wound. Usually patients don't seek out wound care settings, specialty clinics for partial thickness wounds. Usually these are full thickness. Let's see, and any venipuncture or art puncture line, that is not considered for dressing coverage. Another thing that's important, and I think next, is that There are kits, like a PEG tube. There's a kit with dressings in it. If we also provided dressings, that's double dipping for dressings. So there are a lot of kits that have dressings in them, which eliminates them from being available to be covered under the dressing, the surgical dressing benefit. Medicare figures their dressing needs are being managed by the kit that's being dispensed. So let's go through this. Oh, wow. Calcium alginates are not reasonable and necessary on dry wounds. What's the reason for a calcium alginate? It's a highly absorptive, clearly. Or wounds that are covered with eschar. Makes sense. You'd be surprised what we see. Collagen-based dressings are not covered for wounds with heavy exudate. That is a change. Since I got here, that change to the LCD happened July 24th, 2017. You used to be able to put collagen on heavy draining wounds. Medicare reserves the right to reevaluate and change the language every 6 months. Usually they don't do it every 6 months. It's every year or every 2 years. But it's our job as the healthcare community, the wound care specialty community, to reach out and be aware of that. Medicare will put out, notices, but they're not going to track you down and say, oh, by the way, that's why the access specialists and the reps. Thank you so much, by the way. This is Andy Cole with BSN or Essity, and he has provided your dinner for this evening, and he supports me so much. I really, really appreciate it.
Thank you.
This is something that everybody, I'm sure, doesn't know, because I didn't know, and I don't know everything, let me tell you, but contact layers, they're only once every 7 days. You're irrigating through them, but they're just.
They must be thinking about venous stasis that gets layer compression dressing.
It could be, but we see contact layers on things other than that. But just suffice it to say, the language in your LCD states every 7 days, and I see Adaptics being ordered like every day. Yeah. And you've got to remember that a lot of these wound dressing covers, like even our friend over here, Andy, and your Cutimed Sorback wound veil, those are really hard to irrigate through and stay in place, but you're only going to get one. Well, it depends on what the HCPCS code is. As you know, out in our world, it's all HCPCS code. But I'll tell you that those Adaptics, several of them are kind of hard to keep on. Now, the silicone-based stay on far more readily, and you can irrigate through them. But contact layers as a whole, as a classification group, are every 7 days. And what I did for you on the wound side is I put the classifications. I created this program, the WoundWise program. And so it is a national program through CCS Medical. And I think it's really important to know the classifications of wound dressings because Medicare expects you to know. It's usually not reasonable and necessary. You see that language in Medicare a lot. To stack more than 2 gauze pads on top of each in any given area. Gauze actually is not highly absorptive. It is not. It's not really an absorptive dressing. So Medicare is basically saying it can be sort of like a contact, but it's not qualified as a contact layer because it's a different HCPCS code, but they don't expect that to be a highly absorptive dressing.
So they want you to use something else.
Yes, there's something far better to be able to use, but you can stack 2 gauze, too high on any wound, and you can change that daily, or actually up to 3 times a day with just regular gauze. Now, hydrogel, see all these things. I was like, really? I didn't know that. Hydrogel dressings are not reasonable and necessary for stage 2 ulcers. Seems appropriate to me, but they're not. They're for full thickness wounds only. Hydrogel filler, now when you're talking about a filler, that's something that's filling the deficit of a wound. It is an addition to your primary and secondary. Do you see why you need one of us? Right? Hydrogel filler for each wound must not exceed the amount needed to thinly line the surface. Right. And they also go down to units of measure with rope. You can only have 2 units of measure, which is 6 inches each, so only 12 inches per dressing. It goes down to unit, they convert to the unit of measure. I didn't. No, yeah. It's getting far more scientific, the benefit, and it does make sense if you think about it. That's why we have all these specialty, colleagues out there, because wound care is a specialty, and I think the generalists are starting to realize that. Use of more than one type of hydrogel filler impregnated gauzes on the same wound at the same time, Medicare says that's not reasonable and necessary. You have 2 different plans for the same wound. I mean, these make sense, right? Some of them more than others. It is not appropriate to use combinations of hydrating dressings on the same wound at the same time as an absorptive. For purposes of this policy, the dressing in contact with the wound base, except for a contact layer, because that's not considered a primary, is what the frequency is going to be as far as the change. So you're not going to have an ABD that you can change, and then down here you've got your alginate and this, that. You have one frequency of change for the entire wound. And it's dictated by what's in contact with the wound base. So if you have, remember you foam people out there and your providers that love foam. Foam is a 3 times a week. It is not a daily. You cannot use it for padding. And in a way, you know, the Hydrogel Blue, the impregnation, it's like, gosh, I wish that they had that in a foam that could be changed daily, because, you know, but it's kind of, you know what I mean? It's a little bit of an oxymoron. It's a great product, but you can only change that 3 times a week. I've had to really discuss my way through that with several providers. And bringing in the Hollister, and now it's the Applause rep, they're just invaluable. They really are. Let them do the heavy lifting, right? Let's see. So basically what they're saying in this very wordy bullet point is that stacking of different types of dressings for different types of indications is not medically necessary and will be denied. It's not reasonable and necessary to use a secondary dressing with primary dressings that contain an impervious backing. Okay, so if you have, if you have a dressing that you want to have it transmittable onto a secondary dressing, and that secondary dressing isn't going to be used that way, or it's not meant to be used that way, it's denied. Remember, a border, an adhesive border, elongates your frequency. If it has no border, you can do daily, depending on what the classification is. If it has a border, Medicare is saying that should be probably on their wear time. They want wear time on that. So at least 3 times a week. 3 times a week. Okay. Dressings not covered. Okay, so I don't know how many of you have heard about Medicare and their determination of 51% and greater of what makes up, what constitutes the dressing. But Medicare is not going, and that's where the honeys come in here. Medicare will does not believe, and I'm speaking generally for Medicare as not a Medicare spokesperson, but somebody who works very closely with Medicare and the guidelines. They do not believe that there is enough data to support dressings that have that are created with greater than 51% of the makeup of the dressing to be charcoal, copper, honey, silver. So the category that the dressing that's impregnated with these things that are accepted by Medicare, there is 49% or less of these components in that dressing. Like silver impregnated calcium alginate is qualified under a calcium alginate classification.
So the calcium alginate is qualified, but silver alginate will not?
No, it is, because the silver is not greater than 50% of the dressing. It's impregnated, so the silver component is less than 49% of the entire dressing. So when you go to honey gel is 100% honey. And Medicare reserves the right to say that there isn't enough data. Am I being videotaped?
Who's doing the determination? Who actually made the final decision?
It's the medical directors and, the clinical experts nationally that come up with these determinations. Although I don't know about you guys, but there are a lot of people buying MediHoney on the internet.
Right, I was thinking too. Right.
Pardon me?
They must be looking at the evidence-based practices
Right. Absolutely. Absolutely. So these are what are not covered by Medicare, which it's important to know what isn't as well as what is. There's another, this might answer the next. I think it may. If not, I'll get you the answer. We need to go to the next slide. So the followings are wound care items, not necessarily dressings, which are non-covered. Skin sealants and barriers, wound cleansers, which was very shocking to me. Wound cleansers are not. This is solutions to moisten gauze, and here silicone gel sheets, not the contact layers, topical antiseptics, topical antibiotics, enzymatic debriding agents. This is one that I want everyone, this is what we call pearls in my world. Gauze or other dressings used to cleanse or debride a wound but are not left on the wound. So if you want to get loaves of 2x2s and saline, because that's what you're cleansing your wounds with, it's not reimbursable. That is considered activities of daily custodial care, cleansing a wound. Now, if you're debriding a wound, you still are leaving that dressing on the wound, correct? You're not leaving that dressing. That you're taking the 2x2, you're moistening it with something, and you're agitating, say, a stage 2 pressure ulcer to remove that leftover epidermis that's still in the wound or the debris. You're not leaving that cleansing mechanism on the wound as a dressing. Medicare will not pay for that. First aid type bandages, which would include like Band-Aids and things like that, OTC. Any item in the Orange Book, which is a pharmaceutical, which Santal is in the Orange Book. Gradient compression stockings, those are not treatment focused, those are prevention focused, and Medicare unfortunately doesn't pay for prevention yet, although some Advantage plans may, because Advantage plans fortify their plan. This is traditional Medicare. So that's why in my biz, you kind of never say never. You just ask the question, okay? Surgical stockings, non-elastic binders for an extremity, or small adhesive bandages. These are not covered under the surgical dressing benefit. Do you still have a question, Joyce?
I actually did about the silver.
Mm-hmm.
Do you happen to know if most of the silver dressings on the market fit that less than 50%?
They do. Now, when you get into the, I don't really want to be brand specific, but some of the 100% silvers, those are actually used usually in burn centers in the acute care setting. This is Part B out in the post-acute setting. So what happens in hospital, it's kind of like Vegas, stays in hospital. Yeah. You know, we're different out here, okay? And people kind of think, and it's been a real awakening for me, that it's all very fluid, but the mentality, the bucket of money, the guidance, the policies differ. So if you're expecting to get one of those 100% silver dressings out here in the post-acute setting, you'll be getting a call from your benefit access specialist, and we'll have to chat about it. Then, of course, the question goes back to what is the plan?
It'd be expensive to do that in the long run anyways.
It would be. You've got to remember that post-acute, you have different objectives. Yeah. Acute care, very different objectives. Okay, next.
Antibiotics, that is medical treatment. Why would
Oh, that would come out of the Part D. Yeah, it's not coming out of the Part B benefit. Oh, it's covered under Part D if they have that benefit. Yeah. It's just not the, remember I'm here, I'm the surgical dressing benefit expert, okay? But you need to know. You need to, I mean, this to me was just like light bulbs were going on everywhere. It was so interesting. All right, criteria for surgical dressings. You have to have a prescription, as we've defined, medical record information, correct coding, and proof of delivery. Does this look familiar? Because it's a repeat slide. It's so important. This has to be there with every claim. Next. Types of wound and etiology. It's really important to understand. Remember when we were talking about what qualifies a wound? Surgical procedure. Most of the wounds I see are not a result of surgical procedure. They're spontaneously creating. Arterial wounds, venous wounds. You know, so you've got either one or the other. You really don't have both in the same. Now you can have a spontaneously created wound that's gone to the OR for debridement, absolutely. But again, it's really helpful if you know the etiology. I do a whole, this is part of one of my, and you'll see on the other side, I do a whole program of education, and wound etiology is number 1 module. It's very important to understand, and that's the first question I'm going to ask that person that calls me and says, I have this wound, what do you want me to put on it? What is it? How long has it been there? How old's your patient? What meds are they on? You know. Okay, so I could talk about this forever, but I won't. Wound assessment. Again, I cannot reinforce enough that 3 measurements are required by Medicare in order to even consider a wound a qualifying wound, and that is length, width, and depth. Now one would say, okay, Laurie, well, you know, what do you think about the measuring techniques? Good question. Because consistency is really what is going to determine if you have ongoing, reasonable goals that are adhering to a healing trajectory. If you don't have consistency in the way that wound is measured, it can look like it's getting a lot worse in 7 days. So it's either going to be the clock method or the longest axis I mean, those are pretty much standard. Yes?
What about multiple wounds on, I went out yesterday and saw somebody who had like 5 blisters in various.
On the lower extremities?
Hmm?
On the lower extremities? Okay, so you do an area measurement.
Okay.
Yeah, that is a great question because we would get these 9 and 10 wounds in, and that's a nightmare to track. No, you just measure the area and see that area reduce. Great question. Great question. Okay, wound assessment. All of these things need to be there. When Medicare polls, they want to know the color and type of wound tissue. And usually you guys are using EMRs that have these, right? So 25 or greater, or 25 to 50 slough, and Thank goodness, because if you need to narratively write all this in, no wonder people were saying, what in the world's going on? Okay, pain, knowledge of disease and wound management, and reimbursement. So those are things that Medicare is expecting. Say if a patient has an out-of-pocket on a dressing, they expect they have an expense, say a co-payment. They expect for the DME and the industry specialists to let the patient know that so that they don't get an invoice for several hundreds of dollars. And that's why we call and talk to the patient and say, this is coming, you understand that, and you have a co-payment of so-and-so for this. They need to agree to that. Okay? Wound classifications based on level of injury, tissue injury. We all know this, it's a repeat, but you would be amazed. There are actually 3 different classifications. Burns are not up here. And Medicare isn't really nuts about burns, to be honest with you. They will cover full thickness injury. They're not saying they won't, except for collagen and a 3rd-degree burn. But, and they won't cover stage 1s. But really for burns, if you have a partial thickness or a full thickness wound, you have to describe it that way with the drainage. So the classifications acceptable are staging for pressure ulcers. There's your etiology again. Wagner for neuropathic, and people say diabetic ulcers. Well, you know what? Neuropathy doesn't necessarily just select diabetics. So I always put Rennie Anderson. She and Betty are my heroes, but because they brought that up and that really resonated with me. You're right. There are people that have neuropathy and have neuropathic wounding that aren't diabetic. So, but for some reason, it's just easier kind of for diabetic, because a lot of diabetics are neuropathic and get wounds. But just keep in mind that not all neuropathic wounds are diabetic. And then thickness would be full or partial thickness. And remember, my little pearl here is people with partial thickness wounds don't really need to seek out wound experts. They'll heal pretty much on their own. These people we're seeing are chronic, full thickness. You can have a very shallow measuring wound on a lower extremity that's a venous wound that's been there for years, and it's full thickness. If you have slough or eschar in a wound, that's underlying structure that has died. Either it's hydrated or it's dehydrated, but that isn't just epidermis. And I'm just going to do my little spiel about regeneration, dermal tissue to epidermis, and repair. Medicare says if you can regenerate, it's probably, we're going to pay for some dressings, but we're not going to pay for a lot. But if you have to fill in with scar tissue, that's significant, and we are going to look at other advanced dressings to augment your plan of care. So when you're getting into tissue injury, the classification, partial or full, here are the different categories that would be covered. Hydrocolloids, gauze and gauze wraps, impregnated gauze, composite dressings, and contact layers. That'll go for either or. As you go just partial thickness, you add to that whole thing and transparent film. That's all that you're going to get for a partial thickness wound. You go to full thickness, that's when you can access your alginates, your collagens, your foams, and your specialty, the big guns. But you have to have a full thickness injury. Next slide. Drainage, drainage, drainage. It's very important. Medicare wants to know the amount of drainage, and they get very particular on what dressings will be covered and what won't. Scant drainage, less than 25% in the dressing. Minimal drainage, usually no more than 25%, and dressing are considered damp. Moderate and copious, respectively, 75%, 25 to 75, and greater than 75, that's just like leaking a lot. You're going to get a lot more variability in your dressings here than you are up there on what's covered. Next. So here we go with my little visual schematic, which I love. Minimal drainage. Now this is where people are going to say, now this isn't a test, but I know that everybody's going, well, wait a minute, minimal drainage. Okay, hydrogels, but you said hydrogels are only covered for full thickness wounds. Aha! So Medicare wants you to use those to autolytically debride. This is why these resources are so important, because you can pull it out and say, what did Laurie say about that? Because it's a puzzle. So we have two elements that we have to keep in mind. We have the level of injury and the amount of drainage. We just said, and you can go back and look on your previous slide, Medicare will cover full thickness injury, or they will cover hydrogels for minimal drainage. But you have to have a full thickness injury to have a hydrogel covered. So basically, hydrogels are only covered for full thickness injury with minimal drainage, which you usually don't see unless you have eschar or you have a lot of non-viable tissue. And the intent is to use the hydrogel to autolytically debride and provide a moist environment. They don't want you adding more moisture to a heavily draining wound, and they're not going to pay for that, which really makes sense to me now that I think about it. Hydrogels, hydrocolloids, collagen, gauze and gauze wrap, impregnated gauze, contact layer, and transparent film dressings on minimal drainage. Those are the only things that are covered for minimal drainage. Now, when you go to the moderate, you get a lot of redundancies there. You get the hydrocolloid, but you get foam, you get collagen, you get alginates, composites, gauze and gauze wrap, and specialty absorptives. And then when you get into the heavy, see the two asterisks? And this is one of your objectives. What two categories of dressings are allowed for full thickness and heavy drainage? And those are the only two that are allowed for those two together. Okay? I mean, as far as absorbing is concerned. You can't, and those, did we say that alginates and specialty absorptives, those are dailies. You can have a daily, and we're going to go into that in a minute. So this, you really have to follow the schematic to know exactly what you're going to pull or what your plan of care is going to be. And they didn't make it easy, but they put a lot of thought into this. All right, next. Category covered specifics. Now we're getting into the meat and potatoes. Sorry I don't have any dressings to pass around, but you're all advanced wound care specialists. But a lot of times we have a lot of fun with this and people. So your alginates, Medicare guidelines, you have to have moderate to heavy drainage, which we've already stated has to be of stage 3 or 4 or full thickness. Both are the same, it just depends on different etiology, right? Daily dressing change, that's a big one. A lot of providers think foam you can change daily. You cannot, it's 3 times a week. If you have a copious draining wound, you want to change it daily. But people think foam is highly absorptive. It is, but it's supposed to have wear time. These are supposed to be changed daily. Ropes are classified as filler, which I've talked about before. So it's unit of measure, 6 inches times 2 per unit of per dressing change, and you can change that daily. Oh, I just said that. So you have the ropes or you have the flat. Okay, Deb, we're ready. Collagens. Oh, collagen is a sneaky little one. So you have to have minimal to moderate drainage. Heavy drainage is no longer accepted under Medicare, and that has been really difficult for a lot of providers because they were changing collagens daily. Has anyone seen that? Collagens are not daily. It doesn't mean you can't do dailies or 3 times a week. It just means it's going to be a first pass denial, and you have to have, because Medicare does not consider that medically necessary, you have to demonstrate the necessity, medical necessity in your chart note. So there's an automatic first level denial on that. But that's part of, processing. And then you have to prove that it's actually warranted. I'm not sure collagen daily, but certainly 3 times a week. We do a lot of first pass denials, and we have those overturned. Primary dressings, they can stay in place up to 7 days. And that is, now what's different between this and the previous LCD that was retired when this new one came out in 1/1/19 is that there was a phrase in the previous LCD that said, depending on the specific product, so if a PI, if the product information guide that came with the product said that you can change daily or every 3 times a week, then Medicare would accept that. They're not accepting, they've eliminated that language in the new LCD. And there are a lot of providers that are not aware of that, haven't caught up with that, and obviously didn't know about that. I just met with a podiatry group in UCLA last week. I've been around. And they were shocked. You know, so that's why it's our job to make sure industry stays up with what the language in these policies are. Not to be used on third-degree burns or any wound with an active vasculitis. That's Medicare's determination. Okay, foams. Oh, my big foam buddies, right? Foam, 3 times a week. If you've heard anything from me that you can remember, 3 times a week on foam. Please do not order it for padding. It will not be paid. It's not considered a primary or secondary dressing if you're padding the, dorsum of the ankle. That's changed 3 times a week, so you get 12 per month, and that's it. Okay, whether it's a border or not. Either primary or secondary dressing, you can use a foam as a primary dressing with a border. Absolutely. It's not to be used as padding, I think. Okay, specialty absorptives. Again, one of 2 categories that you can do daily for highly exudating wounds. You see how your options have limited now? Medicare's pulling these claims and saying, what's going on here? Okay, moderate to heavy drainage. That's what the Exusorbs, Extrasorb, Exudries, ABD pads, that's what those are for. They expect those to be every day, at least 30 of them. Now the size, I'm going to get into the size in a minute. The size is what the ABDs only come in 5x9 and greater. They don't come any smaller. So you might not get an ABD, you might get an Extrasorb. That's a 4x4, but it's the same category, okay? If you're calling out brand specific and there isn't a dressing, there isn't an ABD in that size, you're going to get an alternate. Daily dressing change, no adhesive border every other day. That's the only thing that's different with a specialty absorptive. Remember I said anything with a border is going to extend your wear time. So if it has a border, it's not going to be a daily. And the only exception to that is gauze. Bordered gauze, island dressings, cover site. That can be a daily. There's always exceptions. Primary or secondary dressing, not to be used as padding. Okay, I think I've beat that one. All right, hydrogels. Oh, this is the little tricky one, huh? All right, hydrogel, full thickness, minimal or no drainage. They want you to use that as an autolytic debriding agent, right? So when I first was learning about this, I'm like, wait a minute, they want you to use it on a full thickness wound, which I personally thought a stage 2 pressure ulcer would be great for autolytic, for hydrogel. Oh, no. Then as I worked with it more, I realized they want you to use it as an autolytic debriding agent on full thickness wounds. They don't necessarily say that, but they make your parameters so limited that that's what you have to do, right? Primary dressing, if the hydrogel sheet, you know that they come in sheets and amorphous. So if there's a border, change frequency is every 3 days. So if you've got a border, that's a red herring. And the hydrogel is classified as a filler. The amount is 3 ounces per month. So usually it depends on how they're dispensed, but just suffice it to say, that's all you get per month. Per wound. It doesn't mean like if you have a bunch of wounds. That would be per wound.
So big wound, but only 3 ounces, but a bunch of little wounds.
If you're measuring the little
wounds, you get 3 times.
Although, if it's the lower extremity and you have 5 little wounds, I would maybe challenge you to be thinking about area as opposed to, but that will limit your availability, correct? Right. Okay, next. Hydrocolloids. Everybody loves hydrocolloids, right? You know what they roll. I've got it in here. Okay, so they're only good for minimal to moderate. If you have a highly exudative wound, Medicare's going to say, wait a minute, there's much better selection. Partial or full thickness wounds, okay, so it can do either or. Occlusive or semi-occlusive dressing. So remember, when you get occlusive or semi-occlusive, you're thinking about, you definitely don't want to have any kind of a bioburden. If you're suspecting any kind of a critical colonization, local, or any kind of infection, this is not the dressing for you. But it's a great autolytic debriding agent. The wear time is 3 times a week. You should not be pulling these off daily. Now, of course, there's an exception to every rule. If it rolls, which it does, they roll, unfortunately, and sometimes they can be a pressure vector, actually, and they require changing because of soiling or this or that. There might be something better that you can use. Okay? Medicare is not just because a patient is soiling. They are not going to increase their frequency. There needs to be other ways in the plan of care to manage that. And that's not by going through 4 and 5 dressings a day. Should not be used on infected wounds. Primary dressings for minimal to moderate drainage up to 3 times a week. The good news is you get to walk out with all of this, and you can reference it. Next. Contact layers, we've talked about contact layers. The intent is to irrigate through them, and that drainage will come through them onto a primary dressing and thus a secondary dressing. They are not an absorptive. They stay up to 7 days, which I think people have been very shocked about. This is one of the, well, there have been a lot of things that people have been shocked about as I've trained on this, but, and now we get to the all important honey dressings. And I think that I've alluded to the fact that it has to be, anything honey related has to be 49% or less in the constitution of the dressing. There are 2 honey derived dressings that are approved by Medicare and have billable codes. One is, and again, I am not a manufacturer specific, I am a generalist, but these are the 2 that have HCPCS codes. So Meta Honey Hydrogel dressing, but it's a dressing, it's a form dressing, it is not the gel. And the Manuka Super Light, which is a form dressing. The Meta Honey Hydrogel falls under the Hydrogel HCPCS category, and the Manuka Super Light falls under the calcium alginate category. No other dressings containing honey have a viable Bill 2 code.
Is the Manuka Super Light, I've not used it, but does that have alginate?
Yes,
Okay.
yes. And it's formed. It's, yeah,
So
but it's not gel.
brand alginate doesn't count.
What is it, honey?
There's a Meta Honey brand alginate.
Formed dressing or gel?
It's a form dressing. It's an alginate. It's like the description of the Super Light.
Manuka Super, there must be something. I'll have to check that because
it
that,
has to do with the percentage.
it
of
could,
or something.
it could.
Because you said that's the only one.
It's Dermascience's brand.
Yeah.
Yeah.
You know, in Dermascience, boy, you know, they really hit the industry running with that.
Yeah.
You know, and boy, I'll tell you, I was, you know, you've seen so much change. It's like, really? I mean, they were doing, people will go on Amazon and who am I to say? You might want to edit that out. Okay, so when we're talking about dressing size, we use a calculator. We put in the length and the width, not the depth, because we are looking at surface area for the size. And we have to figure how many of these dressings would Medicare consider reasonable and necessary to cover that size of a wound, and is there something more appropriate that we could send that would reduce the amount of dressings and cover bigger surface area. So we do this with every wound.
So is the expectation that the patient or the person giving the wound care would be cutting them?
No, the expectation is not that they would be cutting. No. The expectation would be that we would get sizes appropriate to meet the surface area of the wound with a 2-inch border around if it's a bordered.
Okay.
Yeah.
Okay, so it's not like,
Yeah, cutting, that is not something that would be advocated.
okay.
Yeah. Okay, so just so you know that it's very scientific, the size. So if in fact there is something that is sent to your patient other than the brand, I'll take ABD for example. ABDs do not come in 4x4s and 2x2s. So if you want a specialty absorptive for a surface area that is less than the size an ABD minimally comes in, you would get an alternate specialty absorptive. And that would be paid for. The 5x7, or I'm sorry, the 5x9 ABD for, these are larger wounds, but say something that is, what is that, 1/2 inch by 1.5, they're not going to pay for that. There are things that we could have selected or that could have been selected that would have sufficed for the plan of care that were smaller. Does that make sense?
Uh-huh.
Yeah. Yeah, so it's like, it's a total science, the size of the wound, and that's why if you want, you know, those lower extremity wounds, when you have all those surface area, you get better coverage with surface, you know, with the area that you're measuring than all those. It's just, that makes so much more sense. Yes, Sarah?
A question about that. As far as what patients are actually billed for and their copay, if I, for that wound, if I ordered them ABD pads versus tiny little small extra dries, is their copay going to be different? Because ABDs are relatively inexpensive.
Let me say to you that the size that would correspond with the LCD will be covered. Patients can buy whatever they want, right? But if they want it covered by insurance, they'll have to adhere to the definitions and the guidelines and the policies. And this is the policy as far as surface area coverage for the dressing size. There are people that, and I've had people up and down the coast, actually, I don't know why it's just on the West Coast, that are adamant about using ABDs, lower extremity wounding, and they've had to buy their own. Okay, next. We're almost done here. So me, in my infinite wisdom, when I was presented with all this information, and I just come out of Theologics there at Northwest, and they love to do crosswalks, and I said, I'm going to do a crosswalk for all this because this is too much for me to remember. So basically, I created an LCD shortcut grid. So if you have a large draining wound and you want a collagen, you go to the large draining collagen. No, it's not covered. If you have a stage 2 pressure ulcer and you want collagen, no, regardless of what you can plug in drainage and classification, it's going to come up the same. This to me has been my biggest seller. So I have distributed this to many a clinic, and it's been really, really helpful because it's so much information to know. And there's a second page to this. If you're interested in this, absolutely. I don't actually have it out on the web. But I would be more than willing to provide you with it if you think it'd be beneficial. I love crosswalks. Helilogics taught me that. Their data was amazing. And just so you know, we're open for questions, but there's 2 pages of references. So there's a lot of good reference tools in here if you want to look them up. Do you have any questions?
I have a question. I don't know. Maybe I didn't understand something. One of your slides was the dressings don't cover by Medicare.
Oh, the ones that are non-covered?
Yes. So, and it's one point was related to trauma. Is it? Am I right?
Right.
So I was just like
Trauma as it's related to like a skin tear. Now a traumatic MVA wound, like an avulsion, that's covered. But trauma as it relates to skin tear and abrasion, those are the 2 words that are associated.
Like an open fracture, for example.
Oh yeah.
I understand.
That's trauma. That is not a skin tear.
So only skin tear.
Skin tear and abrasions.
Category of the skin tear, right?
It gives the impression that it is more of a superficial type of injury, and thus Medicare has decided that it would not be medically necessary to cover those types of dressings, which can be procured at over the counter or like Band-Aids, things like that.
Even like a full thickness.
What you need to do is write full thickness. There are a lot of ways that integumentary can be damaged. And full thickness with the description of drainage is going to support advanced wound care under the benefit. Just be aware of what you're documenting, because a lot of, that's what those are the things. And I'm not telling you how to document or what, but I'm just saying that these are the things that are in the guidelines that are not covered. So, and I've said that I have seen injury due to moving, movable skin, otherwise known as skin tears, that are significant full thickness injury and appropriate for advanced wound care. Did that answer your question?
Yes, you did.
Okay.
Okay, thank you. And what if the DT was like open, spontaneously open, like deep tissue injury?
Yeah, okay, so a DTI, it's a great question. So DTI is a new description, a pressure-related injury added to the NPUAP definitions. I want to say, when did that happen? 7 years ago? Something like that. So they've, DTI, it evolves. Those wounds evolve. If in fact the damage has happened at the muscle fascial interface. So you can reverse. I have seen a DTI reverse, and it was amazing. I was working at Northwest. Who's Northwester in here? Oh no, you're not from Northwest, are you? Harborview, okay. And I was shocked because we immediately intervened, got the patient on a surface, an appropriate surface, went back 24 hours later, and that butterfly DTI was gone. That's the only time that's ever happened in my experience. What usually happens is by the, have you seen that?
It's like Kennedy.
No, well, we thought this was gone. I was so amazed, and it was very impressive. But that is the exception, shall I say, rather than the rule. So those DTI injuries, when in fact that deep muscle has died and the circulation has been impaired to the point where you have tissue death, the body is an organic substance. It's got to rid itself of non-viable matter. So that wound is going to evolve into a full thickness injury with eschar covering. You know it's full thickness by virtue of the eschar being present. And now the plan of care is to remove the dead non-viable tissue to actually see what the wound base looks like. So just by virtue of being a DTI, it sort of intimates that wound is going to evolve into, people say, my wound blew up or the wound blew up. Well, that's just a textbook description of what happens with a DTI that evolves into a full thickness injury. So I suppose the moral of the story is DTI, you really have to watch them very closely. And when, in fact, a wound does progress or evolve, and I do litigation. I'm an expert witness for pressure ulcer cases only, and lawyers will really zoom in on that. And the evolution of a DTI, that language is very important because that wound the body has to rid itself of the non-viable tissue. So it's not like it was, abusive care or negligent care. It's like the damage was there. Body's ridding itself. I'm not saying it wasn't negligent, but I'm just saying that, a lot of times that is looked at as the default, when in fact that DTI could have happened regardless of what you were doing because of patient coexisting comorbidities, etc. So you will have evolution of DTI if in fact that muscle has died deep, and it will evolve. And you need to rid the body autolytically, or maybe they'll take him in for sharp debridement, I don't know. Did
Yes, you did.
that help?
And I
Okay.
have another question.
Yes, Eugenia, my gosh,
No,
it's been too long.
I know, sorry.
Haven't seen you in so long.
Oh, you haven't seen me.
I know, it's great to see you.
Thank you. So, hospice patients.
Yes.
And especially a couple people who I'm taking care of now have fungating wounds.
Mm-hmm.
And does it relate anything with the hospice care? So Medicare does it?
The Medicare hospice benefit is a different benefit than the Part B benefit. However, wound care is all inclusive in the hospice benefit. So yes, you would be able to access dressings under the hospice Medicare benefit, but that is not the program that is not in this LCD.
Okay.
It's in another LCD, which is that hospice is an individually funded benefit, of which dressings are included for qualifying wounds. But fungating wounds are interesting because fungating wounds actually can heal with adjunctive therapy. I've seen it. I didn't believe it.
I've never seen it.
Yeah, it's amazing.
Because I've seen only one hospice.
Right. Well, this patient actually was not a hospice patient, but came from another country here and was getting aggressive care by her family. And I was at Northwest Hospital. And there was adjunctive therapy, be that chemo as well as radiation, aggressive treatment with the intention of surgery. And that wound actually, in about 3 months, actually healed. It doesn't mean she was cancer free. But if you would have told me that wound was going to heal, I'd have told you, no, there's no way. So never say never in this business. I mean, I've been around long enough to have seen a lot of amazing things.
Were they using topically for the fungating?
We were using the hemostatic powder because it was very friable, and then a silicone cover and lots of absorptives, and then like a Tubifast or a Surgilast dressing for the trunk. And changes were 2 to 3 times a day initially. But what that does also is that autolytically debrides, and then the hemostatic powder would at least assist in keeping that bleeding to a minimum. And then with the adjunctive stuff that was going on, it was amazing. I mean, not everybody's going to respond that way, but I will sit here and tell you that I have seen I have seen a fungating wound that people thought was absolutely, I've seen it heal.
They've always been comfort care.
This person was not at that, and younger at that, and came from actually outside the U.S. And I don't know the ramifications of all that, but it was very aggressive treatment. Very amazing. So never say never, right? I suppose the moral to our specialty is, well, thank you for coming, and I hope that you take away information from this that you can use in your practice immediately. I mean, I love to go to the conferences and all, but I mean, I don't see you using, polyethylene coated stuff, I mean, it's kind of hypothetical, but this you can use. Just so you know, there are product lists in here so you can review and kind of see what kind of different products align with the categories. And then there's a form if you're ever wanting to put in any order. I just wanted to put that there. But the thing that's nice about these order forms is it goes through the elements that are required to submit a clean claim. They are cumbersome, they're overwhelming visually, but it all has to be there. And if you get these with multiple wounds, I would encourage people to, for the lower extremities where you oftentimes see 10, 11, 12 wounds, look at the area. Yeah, look at the area, and then the area will reduce as the wound area surface improves.
I've got a question.
Yes.
So obviously patients who are in the clinic environment,
Mhm.
the outpatient environment, they would obviously their insurance would the clinic would submit this paperwork,
Yes.
and a patient would probably get their supplies. But for home health patients, if they're traditional Medicare, then the home health agency has to pay for the
Correct.
supplies. But if they're a Medicare Advantage, it's then, I'm thinking, worth it for the home health nurse to contact
Absolutely.
a vendor, a DME vendor, and see
Absolutely.
if their insurance will.
So let me just speak to that. It really is all the reimbursement, the money flow. So Medicare, as the insurance company, outsources the risk, basically. So what they're doing is taking the amount of money that they would assign to a Medicare beneficiary to care for them in the event that they get into some health problem. That will go then to the next care provider, which may be a home health agency that's certified for Medicare and the patient qualifies for that benefit. If there is an insurance company, let me take Humana for example. Humana has a Medicare Advantage plan by which they contract with the home health agency because the monies from Medicare have been paid to Humana to manage that Medicare demographic. So Humana now is the one that is going and contracting with the DME, with the home health agency. So we can, hi there.
Is this family to family?
No,
Sorry. Okay.
it's
sorry.
not, but we're family,
Yeah,
So actually dressings can be sent directly to the patient's home as opposed to a Medicare certified home health agency where the money comes directly from Medicare to the home health agency. If in fact that home health agency that's getting a rate to care for that Medicare patient, also then they bill us for dressings, they're double dipping. You see what I'm saying? Medicare's paying twice. They're paying two benefits for the same patient. With the Medicare Advantage plans you're seeing now, the outsourcing of the risk. So Medicare's taken out of it because they've paid to Humana. You take care of patients that join your Medicare Advantage plan, and here's the money per patient that we're going to pay you yearly. And then it's now Humana's job to go contract with the home health agency of their choice, with the durable medical equipment company of their choice, with the prosthetic company of their choice, with the pharmacy company of their choice. And then all of us can ship those claims to Humana for the care of their capitated Medicare Advantage patients. So just because you hear home health, it used to be from DME's side anyway, home health, we can't use them, they're a home health agency. We can't send it to a DME because they're a home health agency. It's not the case anymore. And that's why it's getting very complex. Yeah, it's getting very complex. And that's why I encourage people to go to the experts, go to the Andys of the world, go to the Lauries of the world. It's our job to know all of this. Lord knows there's enough for the providers of wound care to deal with, right? And we can triage through like an algorithm very quickly and get you on the track that you need to get on rather than trying to call, and do all that, because it's very complex. I'm kind of now really starting to get in the groove, and I've been doing this now 2.5 years. And I've done wound care for half of my professional career. So wound care in and of itself is a specialty, and it's being noticed as that. The generalists, primary care, they're really coming to the agreement that this thing is bigger. It's not just gauze and tape anymore, right? And all of the things that go into the plan of care. I'll be the first to tell you, dressings are not a panacea. That is not the entire plan of care. And I've said that ever since I've been with this company. Don't ever think that I'm going to go out and say, oh yeah, the dressings are the catch-all be-all. They're a part of the plan, but they're not the entire plan. Yeah. But I can certainly tell you what Medicare will pay for and what they won't. And that's the thing. I feel responsible to be that benefit access person for that beneficiary that may have had autolytic breeding going on for 3 months, but because it doesn't say sharp in the record, they're not getting their dressings. That's, there are those of us, if you know anything about me, I tend to get pretty passionate about things, and I'm really passionate about if you've worked to access, to amass benefits, if you qualify, then let's get you your benefits, especially where wound care patients. You can't go without dressings, right? Unfortunately, there are things that people may have to pay out of pocket for. We discussed some of those today, and that's the Medicare. Now, people can buy whatever they want, because everything is accessible, it seems like now, on the internet. But it's not certainly under the guidance of a healthcare professional. It may be. You may have a provider that says go. But if you want your insurance to pay for it, there are things that, and people don't always agree with what their insurance is going to or not going to pay for. We have that discussion with them. I don't think there's anyone in my company that would dispute that. Really. We don't make the rules, but we certainly have to educate to the rules.
Okay.
All right. I guess that's it. Thank you for your time so much. I've enjoyed myself very much.
Thank you. All right, Laurie.
I'm at a loss for words.
Okay, and we're going to turn our time over to Andy, right? Sorry, I'm having a really hard time. It's a long week.
I'm sorry, Andy.
Here you go.
Oh, you're fine. Man, I have to be on video?
Thank you for...
Yes, you
What?
do, Andy. Come on.
You stand right where you're at.
Okay. So I'll be quick. So I just want to touch again on what Laurie said. I think it's our job to educate you. So from my side as a wound care rep, I think it's important that I educate you guys on what's the newest and greatest thing that's out, or educating you on what the difference is of our product versus another, and so on and so forth. So I do, based off of what we talked about today, I know it was a lot, and it can be exciting and overwhelming all at once. So I'm only going to add to it, of course, and confuse you a little bit more. But so I'm with BSN Medical, and I think our greatest thing that we have is this. It's called Sorbac. So this is an antimicrobial dressing. There's no chemicals inside of it. So you can use this on newborns, pets, anybody, even if you have a skin irritation. So this was first developed over in Europe and Switzerland. For the last 20 years, still to this date, there has been no known issues like skin irritations, no known resistance to it. So what it is this is a fatty acid derivative that will manage bacteria through a hydrophobic reaction. Meaning when you place this onto the wound like a wound contact layer, any bacteria will be drawn to it. Once it binds to this dressing, it is irreversibly bound. So basically become inert. So you can leave this in place for 7 days. So a good example is like everybody's probably seen like a wound vac before. You can set this down, stick your black foam over the top. You can still do your dressing changes, but leave this in place. Okay? Easy enough on that one. And this is very cost effective as well. So this would be like a good idea or replacement for silver or any of your topical creams that you're using on there to help treat or prevent an infection on that one.
Just due to the lack of inflammation because there's no kill rate of the bacteria, so I think that's important.
So good one on there is if you were to look at this in 1 square centimeter of this, in the first 30 seconds this will bind 10 to the 5th. In the first 2 hours this will bind 10 to the 8th. So even superbugs like Versa and MRE are still going to be able to bind to this.
And you take it out, and those bacteria, the cell wall is not destructed.
Yeah.
So you don't get that inflammation and erythema that you do with kill rates like with silver.
Yeah.
It takes the intact bacteria out of the wound. It's called DAC therapy. It's pretty impressive.
Does it get saturated?
Nope. So one thing you'll see, or like what happens before is you could stick this, if it happens that you stick this into a dry wound, which I wouldn't recommend, but sometimes like if you have an absorber over the top that causes the wound to dry out, this can stick. So then people can freak out and be like, oh my gosh, what happened? Well, that absorber actually dried it out. So I would just soak it with saline, Dakins, whatever that you guys are currently using, moisten it up, and then just pull that out on top of
I
it.
think
But
maybe Joyce is saying, does it get saturated so it becomes
Nope.
ineffective.
Right.
No. So you'll look at it, so it can still colonize on there. So if you can see it's a critically colonized wound, you might want to do every day of a dressing change. Like you'll frequently look at it and see on there, but it's not going to do anything
What's
to.
the green color? Is that
So good question. So this is a natural vegetable dye.
Okay.
Don't ask me which one, because I already asked that question when I first started. And it's a natural vegetable dye that just makes it the green.
okay.
That's all it is.
Does it have mesh in it?
It's
Okay.
basically like a mesh material. I can pass that around if you want. So like newborns can still use this because there's no chemicals in it. So like when you put in silver into a wound, it kills the good, the bad, the ugly, as we used to talk about. But you go back to that inflammatory stage. No, that comes in as big as like an 8x8 all the way down to, so here's like a little small one. I have brochures that will show you different forms of Sorbac. So my company is also the only one with a super absorber and the Sorbac technology on one dressing. We're the only ones with that on the market right now, so you can have a super absorber that also has an antimicrobial dressing on one, so it's considered one dressing.
This is, did you say this is some kind of lipid-based fat?
A fatty acid derivative.
Oh, fatty acid.
Yep.
So
It's basically it
attracts
Yes,
the fatty
yes.
layer of the bacterial wall,
so
and
all
it adheres to that.
so all bacteria, even fungi,
Yeah.
are laced with silver with water on the lining of it, so that'll bind together. It's almost like if you took oil and water, dumped in there, and you shook it all up, but yet it still comes back together. It's another way to kind of look at it.
Who has not seen the human Sorbac product or the green? Well, yeah. Yeah.
I've heard of it, but I've not.
Yeah.
Interesting.
So
Your home health and your hospital.
Yeah.
So
Very acute.
so this is a good transition for both. One, cost-effective side. Well, technically for both of you, cost-effective side, basically to treat and prevent. But then you can still use that both sides of it, where it's not going to dictate on how you can use one versus over the other, like super absorbers.
And there's no allergic reaction to it.
Nope.
Sounds like it.
And so I wanted to show you our super absorber, right? Because after everything that we lead there, ours is daily. So ours is not considered a foam. Okay, when you think of super absorbers, most people think of like a sponge, right? So as it collects up, what it does is it starts to pool in there, and then you're causing maceration. So what my company has done is we've provided a super absorber where, one, you can see there's expansion space inside. There's no hard borders in here on there, so we're eliminating any pressure points as this grows, okay? So why ours is different is we've put gelling beads and agents inside of this, so when it, one, starts to absorb, it'll sequester inside, so it eliminates maceration. So if this was to get wet for my demos, I pass it around, you can feel this moist cooling almost like an ice pack, but it doesn't get you wet, so that dressing stays dry. On top of that, everything that sequesters inside of there turns into this gel, so that way it doesn't pool out or do anything for that, but it still gives you that moist balance throughout the wound with those gelling beads in there. So that's where it gets that cooling effect inside of there.
You can see why you wouldn't want to cut that.
So, but I do, so that's a funny thing, right? So I asked, has anybody ever seen a super absorber explode before?
Yeah.
So take one, we do all over, right? So I do it for my demos, because everybody says, what happens if it explodes? Knock on wood, I've never, even with my company, have not heard of one exploding yet. So what I do is, once you fill this up, so I can give you samples to do it, cut it completely across, cut it in half. Because what I want you to see is when it does ball up and it pools out, it's this giant ball of gel. Okay, so even if you were to break it up, and I do that as well, because like if you're thinking under compression wrap, right? Break it up, then I take my water on the plate and sprinkle it on there, and you can see it pools everything away. So it forms together into a gel, almost like a diaper. You need to edit that one, I didn't say that. But it acts in that way. The other one is, the reason I have you cut it in half is when everything falls out, I want you to keep the dressing top part of it and feel it. It's completely dry. And the reason I think that's important is because that's what's on the patient's wound. Okay?
What's the adhesive on? Is there adhesive?
Oh, it's like a polymer lining on it. The last coolest thing with ours is this will do a soft debridement. Okay, so there's another part that we were talking about. So yes, on this one, I'll do a soft debridement. I always use that carefully, a soft debridement, because I don't want you to think it's going to replace a debridement. Okay?
Although you can write on
Yep.
You could say debridement.
Yeah, so on this one, but I just caution, normally when you tell somebody the word debridement, they think it's going to replace everything
Just
for
think
it.
about
So
what you're trying to appreciate.
accomplish.
Yeah, that is liquefying of the non-viable tissue, which that's,
And this is very skin and tissue friendly as well.
that does not
On
have
there.
a border on it though.
Nope.
That isn't an adhesive border, so that would be a non-bordered.
Okay.
So a daily, you can definitely do that daily.
And I have brochures on all these.
What is the name of that?
This one is called Sorbion, and I have brochures for you. They have all the sizes, everything for it. That way you don't have to memorize everything that I tell you
How
today.
is it different from the Hydrogel Ultra that you used to make? Do you remember Hydrogel Ultra that you were in the company a few years ago?
I wasn't with them when they brought it on. This one,
Hydrogel Ultra. Remember when that's the
I think that's the same thing. I'm not sure.
with a different name?
I wouldn't be able to answer that one, only because I haven't seen that one. So I wouldn't know what the revamptions are, what the difference is between the two, or if we just changed the name.
Yeah, that's.
Yeah, because we couldn't get it all of a sudden, and then we went to a different brand.
Yeah.
But I never heard that.
Diaper Technologies.
Yeah, we
changed
went to a
them.
different.
Yep.
And Deborah was still working with us, and we went through a trial of different things. I think, yeah, you were still there. Yeah. Towards the end.
So then the last one I'm going to show you, this is called Hydroactive B. The reason I like to show this one, and I like to call this dressing a 4-in-1 dressing. I think it's a little bit easier to remember versus the name, but the reason I like the 4-in-1 is because you're going to remember why I call it a 4-in-1. Okay, so one, you see it's green. So it's got your antimicrobial dressing to help treat and prevent an infection. It's got an absorption pad on there, so it will absorb. This will do an autolytical debridement for you as well and help cool the wound all in one. So those 4 things right there with your one dressing that you could stick on there.
Good dressing for burn.
I see a lot for radiation burns, road rash, because you got to think of a lot of those patients, they can't tolerate
Right.
anything that you stick on there. Doesn't matter if it's gauze or like a hydrogel, anything causes irritation. So that's why I like to tell people, think of your 4-in-1 dressing on here that you can stick on there.
What is that classified as?
Well, so that's the funny thing is the smaller version of this, which is like a 2 3/4 by 2 3/4, is reimbursed daily. This one's a 5.5 by 5.5 is 3 times a week.
But you know the
Um,
name? Is it an alginate?
The bigger one I think
It's
is
an alginate.
just the alginate. The
Yeah,
smaller
but-
one is not.
So it would be a hydrogel. I don't know. I gotta.
I see. This is why I'll show you all the stuff, work together on, educate you on it, and then we can go back and forth to say reimbursement wise what works with this. Yeah.
Who makes that dressing?
So
Is that the European?
yeah. So this is my company. So BSN Medical.
Okay.
We're now known as Essity, so we merged with the Joke Stockings. We merged with an orthopedic side as well for like casting and splinting, adult diapers. We've merged with the Essity now as a giant company to do like stewardship of care. So that's kind of our newest, greatest thing, is that we're all in one company now. So basically we have a continuum of care. So I get to come in first and kind of address a wound. So I have a plethora amount of products that I can show, anywhere from gels to bandages all the way up to your super absorbers and stockings, compression. But these are kind of like the 3 that I think set us apart the most and what I think benefit the patient and clinics the most as well.
Pass that green
Mm.
one.
Definitely, I'll pass all these around so you guys
Do you
can
have
hear.
literatures for all?
Oh yeah,
We have
yep.
stuff on the back table. Please take some pens. They're actually pretty good.
Yeah.
Our pens are pretty good.
Am I okay to set it down? I don't want to.
Thank you very much.
Okay.
For the opportunity.
Yeah, thank you everyone for coming to SWOC. Come next month and we'll learn about continence issues. So, all right.
6:30 is a good time.
Is it?